My name is Eve Fields, and I'm a psychiatrist and the director of integrated care at the South Carolina Department of Mental Health. Um, I was asked to speak today about some of the efforts that we've been doing on tobacco cessation. And this started about in 2019 when I came onto the South Carolina Department of Mental Health and then was asked to do work in integrated care. And we conducted our foundational assessment of integrated care services. Louder. This work started as part of our integrated care foundational assessment, where we looked at the entire state of where we do services for South Carolina. And let me just step back one bit. And our state is a little different than other states in that all of the mental health centers are overseen centrally by the Department of Mental Health. In other states, each mental health center may be its own entity or respond to a local government. But in South Carolina, all of the mental health centers report directly up to the South Carolina Department of Mental Health. So when we were doing our foundational assessment, we were looking at all of the centers, all 16 of them in the state of South Carolina, which covers the entire state and all of the counties. And one thing that we did was to ask for a list of diagnoses that were the most common diagnoses. And in that, I noted that our diagnostic rate for tobacco use disorders, who wants to guess what that rate was that we had? Anybody want to throw out a number? What? 8%? Okay. 80%. Okay. It was 3%. And that was a little bit of a red flag to me because we know that about 18% of South Carolinians smoke. And we know that people who have a severe and persistent mental illness have smoking rates that are higher than the general population. So why was it that our rate of diagnoses was only 3%? I don't think it's because we were doing such a great job connecting patients to tobacco use services and had such a strong policy that they were not smoking. I think it was, in fact, that we just were not making the diagnosis. And so in my mind, the thing that's, you can't refer people for treatment if you don't know that they need treatment. There's not a way to identify them. So we started with bringing this up with the group that was pre-existing. We have a joint state tobacco cessation group with DEODIS, DHEC, and the Department of Mental Health, which originated in some of the first tobacco policy summit in 2018 in the state. And we've had ongoing meetings monthly with this group and bringing this up and talking about what resources we had available. So some of the things that we were doing were DHEC sponsored some tobacco cessation trainings for our staff. And we also started working on other things to do, including building a toolkit for South Carolina providers that we were able to host. And this has specific tools for providers in South Carolina who are working for the Department of Mental Health or DEODIS. Things that seem sort of obvious, but like the material ordering form for DHEC to get more materials into your clinic about tobacco cessation, the fax referral form for the quit line. I wasn't even aware of how easy it was to make a referral to the quit line. And so educating the providers who work with us about the availability of these resources. We then also were able to work with the UCSF, the University of California at San Francisco Tobacco Cessation Program, and had a speaker that we were able to come, who was able to do a virtual webinar on the importance of tobacco cessation. And then we've also been, I started in December of 2021 with going to the medical director meetings and just putting a plug out there saying people are not diagnosing tobacco use disorder. We can't connect people to treatment if we don't know. And so that rate initially, as I said, was 3%. The last monthly treatment report that we got was 6.5%, which is still far below what we believe it should be. And we have continued efforts to work on that. But that was really with minimal intervention. That was really with just going to meetings, talking to the medical chiefs, talking to the center directors, and asking them to talk with their staff and make that diagnosis when it was appropriate. Even if that diagnosis is tobacco use disorder in sustained full remission, because we know that in order to recognize that people might be vulnerable for a relapse, you have to know that they smoked to begin with. As we've gotten more people trained, we've also had interest from our inpatient physicians and the inpatient group about tobacco use disorder, because a lot of the patients that are in our hospital system will be put on patches for the month, 2 months, 3 months that they're there. And then they get out of the hospital, and what's one of the first things they want to do? Smoke, right? Even though they've already had this period of, abstinence for a couple of months. So we've been working with what we call our transitions team, which helps people making that transition from an inpatient to outpatient setting to get them trained with tobacco treatment specialist, making workflows to get patients referred to the South Carolina Quit line so that when they get out, that those resources are there if they need them, for meaning nicotine patches or coaching, et cetera. And then we've had, in a lot of patients, again, their first thing that they want to do is to smoke when they get out. And so there hasn't always been as much reception for looking at this in terms of patients wanting to engage. So we have started thinking with the inpatient directors about developing programming that they can do on the inpatient unit with patients to sort of prep them or educate them about the difficulties that they can have with smoking cessation, including that a lot of the medications that we use, particularly for patients with psychotic disorders, you need a much higher dose of the medication if you are a smoker. And so what will happen in this cycle is that patients will be put on a medication like olanzapine. They'll be on a nicotine patch in the hospital. They'll be on a stable dose of the medication. They'll be discharged. They'll leave. They'll start smoking again. That medication level in their system will get lower as they smoke. They relapse, and then they're back in the hospital again. So again, there's a lot of compelling reasons to do this, which can immediately affect a patient's life. So educating the patients more about this. So we've approached this in a multimodal way with educating our providers, using data to track what we've been doing to increase that rate of diagnoses. And eventually I'd like to get to the point where we're looking not just at the diagnosis rates, but we're looking at converting patients from active smokers to being in remission. But before we can do that, we have to know what our rates are to begin with. And so that's where we've started at looking at this first.
I am Kellie Lamb. I'm with the American Cancer Society, and I am Senior Program Manager with Tobacco Control. I am covering actually 4 states right now, and one of them being South Carolina. So I am new to the South Carolina area for coverage in tobacco control. So my experience is going to be really limited to other states and work that I've done. And then this is kind of a new project for the American Cancer Society. While they've always had education surrounding tobacco and cessation, with partnering with ACS CAN, which is our kind of our sister partner. They do the advocacy and kind of the policy part of changes on the state and federal level, supporting them on doing more education with tobacco control in states that still have a higher than national average in tobacco use and lung cancer mortality. So the goal is to really increase cessation in the states that I'm working in, and there's 13 states. And again, I'm only covering 4. And then again, backing that up with, if we're decreasing tobacco use, we're going to decrease lung cancer rates. So, my background really falls in tobacco control on more of like a local level. So I worked a lot in Mississippi. There was funding from the Tobacco Settlement Agreement for Mississippi Tobacco Free Coalition. So there was 34 of us across the state that focused on different counties depending on the population, and which was great because it covered a lot of the areas, whether it be higher population and your rural areas. So working in some of these rural areas in Mississippi, and I have worked some in Louisiana, really seeing some of the issues of people getting tobacco cessation, getting referred, getting the help that they need to quit tobacco, and how can we educate communities. So I wanted to touch on some of those issues that we've seen over the years and kind of ideas of what we've done to really enact. And again, my position now with ACS is to kind of take those best practices and initiate those in some of the states that I'm working in. So of course, when you look at some of these rural communities, some of the biggest things they're going to face is access, right? So they're not always accessible to tobacco cessation services in person, or even a clinic now. I'm sure you guys have seen within your own state and within Mississippi that we have a lot of health systems that are not making it, and they're closing, and we're losing services in some of these rural communities. So the access part with transportation. So how can we bring it to them? And I will say it's been really great to see the transition of tobacco cessation over the years, of it being just a quit line. That was all that you called. And it was amazing. The program, I know there's a state quit line here that offers free counseling. I think they offer gum, the lozenge, and the patch, maybe. And so I know every state's different too in what they offer. But now it is on a computer. You can chat with somebody. You can text with somebody. There's a lot of components, but we have to make sure that the patient knows that. So getting that message out of what's provided and what's accessible to them, even if they're in a rural community. Sadly, then you have the infrastructure of not being able to have broadband services. So some of these communities don't even have access to internet and where they're at. So how are we working with these states and these communities to make sure that they have access to internet? So that gets really tricky. So, trying to think outside of the box on what we can do to get services to them through education, and really going even down to a deeper level of health literacy. People not really understanding the lingo around tobacco cessation. I know the previous speaker was really great, and that resonated a lot with me because I have been in tobacco for so many years. I understood a lot, but for the lay person out there, they don't even understand what cessation means. They don't understand what tobacco means. I always tell the story that I would, when I worked in tobacco for years, I was considered the tobacco lady. So everyone who quit was very excited to tell me when they quit, or which I was excited to hear those stories as well. But, I remember somebody coming to me and saying, "Hey, Kellie, I've quit smoking. I'm doing so good. I'm just using these little snooze things now, and I just suck on those." And I'm like, that's not quitting, So, and he was a highly educated, degree, did insurance for a big company. It's not even always about education, but it's about literacy. And what are we doing to make sure that these people understand? And I think that goes back to youth. We've partnered a lot with schools over the years. How do we start from a young age to making sure that they understand what nicotine is, what tobacco products are, how they work? I had a great story that I worked in a very rural community in Jackson County in Mississippi. I went every month and spoke to the coaches, did a PE. So every month I talked to 6th, 7th, and 8th graders for years and did tobacco education. And about the 5th year, one of the high school coaches contacted me. He'd heard about my work, and he was a baseball coach, and he had me come and speak to his baseball group. And he said it was actually the first year that he did not have one athlete using any kind of spit tobacco. Of course, in rural communities, we see a lot of spit tobacco, and what you see in youth because it's easily hidden. So I felt like that was a win for all of my service in the middle school and kind of catching them at that age before they got to the high school level. But partnering with these coaches and finding champions within your communities, I think a lot of times too, and going back to coverage too, South Carolina is really great because I do work in multiple states. I do know not every state has great Medicaid coverage on tobacco cessation. So South Carolina does have full coverage where all 7 FDA medications are covered, all counselings are covered. There's very little barriers to that. And there's a lot of states that are still fighting for that kind of coverage. But how do we make sure that those Medicaid recipients know that? So again, partnering with these providers. So we try to somehow figure out ways to get in front of them, whether it be provider conferences. I know I recently went to a Medicaid conference that reached out to all providers who serve Medicaid patients. How are we getting in front of them to make sure that they understand what the coverage is? And thinking outside of the box, you may not have a physician or a rural clinic in that area, but maybe you have a dentist. Are we really accessing all providers at all levels? And we know that research shows that the more that they are inundated with the education of quitting and why it's important from all different aspects, the more likely they are to quit. So if they're not if they're hearing it from their provider, that's great. But if they are hearing it from a dentist or a social worker, or some of them already have lung health issues, they're respiratory therapists. I know Oklahoma's done really great. Their hospital association has some money from partnering with TSET, which is their tobacco settlement agreement money, and going in tobacco cessation, starting with the health systems and doing in the inpatient. So anytime somebody is is positive for being a nicotine user or tobacco user, they are automatically referred to a respiratory therapist, and that respiratory therapist has been trained to talk to that patient about quitting. So using different people and different components to make sure that it's coming up in conversation. And that's getting these providers to maybe a brief intervention tobacco training, which is only a couple-hour training. How do we connect them with these kind of trainings that they understand how to speak to a patient? Again, it can be very touchy. I did employee wellness for a hospital for a few years, and one of their initiatives was to, we did a screening, blood screening, weight, nicotine tests, and if they didn't pass on some different things, they had to do something, a reasonable alternative so they could keep their insurance rates. And one of them was around weight. So imagine talking to somebody about their weight from even a wellness component within a workplace. So I had training on how do you speak to somebody to not offend them culturally. A lot of times it's a culture thing. So how do we talk to them without making them feel bad for their choices? We all know that a lot of this comes from marketing from the tobacco companies. I think everybody should be trained on the marketing of tobacco industry and really understand how it's inundated into our culture, into our social media, into our lives without us even truly knowing. Even I just traveled here yesterday, an 8-hour drive, and stopping at gas stations. Where do you think that those tobacco signs were? They were not at my eye level. They were down here at the eye level of a child when you walked into a door of a gas station. I'm not seeing that. That's for the children that are coming in. So people really understanding that it's not their fault, and having that education of how to speak to them to really inspire them and motivate them to want to make this change. So finding partners within our communities and bringing those together. I have found that there are a lot of people who work around tobacco control, and they're trying to work in these groups and make a change, but can we bring them together and really find champions and coalitions? So in Mississippi, that's what we did, is we built these small coalitions, and we would have teachers, we would have people from the medical industry, we would have business owners, all working with your churches. Again, churches can be a strong component in a rural community. They usually have some of the biggest influence on that community. So are we empowering our churches to really look out for the health and well-being? Speaking engagements. I know over the years in cities that we have worked on smoke-free ordinances, or counties, partnering with civic organizations on talking about the dangers of secondhand smoke. You come and empower these business owners or community leaders to really understand the impact of what tobacco is doing to their community, and they're more motivated, empowered to speak up to their community and really connect them with the resources that are out there. So I feel like I've kind of went all over the place, but sorry. So finding champions was always key to making the change, and they are out there. I know being with ACS, it's been really great because you work with survivors, and that's kind of a terrible way to go. But sadly, someone who has survived cancer because of mouth cancer or lung cancer because of possibly tobacco use, but using them as speakers or people who really reach out to communities to make a difference, because they don't want someone else to go through what they have gone through, can make a difference. So finding those people and using their stories to really share with their community and their loved ones can make an impact. But I think the biggest thing that I have found is being able to talk to somebody more on their level, making sure that our physicians are trained through these brief intervention tobacco trainings, to be able to speak to their patients. And it, again, not being just a physician, but anyone in the medical industry, or again, a social worker or someone who's working in the community within wellness, or even a lot of larger businesses have, someone that does wellness or human resources, are able to talk to people and give them the resources. And the other is finding these champions that really speak out, that can inspire a community. And sometimes it can be tough on that person because they carry a load. So I always recommend finding more than one if possible, to really rally a community around the health and wellness of their community, and why tobacco is so key on getting people to quit and finding them the resources that they need. So I think that's all I have. Thank you.
So let me tell you right now, you were on track. You stayed on track. I'm gonna tell you guys right now, I am not gonna be as organized as the last. I'm gonna be all over the place. But let me at least start with introducing myself. I'm Onjewel Smith. I'm the Southern State Strategist with Americans for Nonsmokers' Rights. And I have some of those crazy states you have, including the lovely South Carolina. But Americans for Nonsmokers' Rights is a national organization, and in the big picture of tobacco control, we get to focus on smoke-free policy. So we work on educating around the dangers of secondhand smoke exposure and the benefits of smoke-free environments. And I say that because even though we focus on secondhand smoke, we're working with communities and our partners addressing health disparities in all tobacco-related illnesses and everything that's impacted by tobacco use and secondhand smoke exposure. So if we were to look at the tree of life and all of the health disparities that are plaguing our communities, and we're talking about stroke and heart disease and cancer and lung disease and everything else. Okay, I should have started with saying I'm not a public health professional. So if I can't get those things right, don't knock me down for that. But what I do know is that tobacco use and secondhand smoke exposure are risk factors for all of those things. And we can't address those things unless we're working at the root of the problem. And we're working on solving some of those issues. And so we like to, so I have an old colleague that used to say, and she was a member of and worked with tribal nations. And she would always say, don't do to us, do with us. And we try to take that to heart when we work with communities. Like, we try to work with communities. And so sometimes we're not the best organization to be out front doing this work. We really do believe that the community knows itself best. And how do you find those organizations that can do that work in the best interest of the people that they represent? So sometimes we may have the resources, or you may have the resources, but you may not be the best person to lead that effort. And finding those organizations that can use those resources with you and work with their communities with you and address the problems and getting to the root of the problems. And again, because if we don't get to the root, that tree is just going to keep growing, right? And so, there's an organization we work with. I'm gonna tell this one story, and from Atlanta, because we've been doing smoke-free work. Like, okay, so Atlanta recently passed a smoke-free ordinance, but there was one key organization that we worked with, and we've been trying to pass that ordinance for years. There was an organization that's real grassrooty, and I'm gonna get their name wrong. It's the Heart Coalition, and Heart is an acronym for something that I should remember. And I could really make this up and just give you some letters for what it stands for, but that would be totally disrespectful to them. And they're just real grassrooty. And we've been working with them since they were like baby grassrooty, right? And we were supporting them to do some work, and they know their community, and they can get into the trenches and do the work. Because, if we show up, even if I look like the community sometimes, I could show up and be like, hey, get out of here. Like, you're not really us sometimes. And I'm going to tell another story. I'm going to come back to another story about that, but y'all hold on for that one. Okay. So this organization, like they were doing what we asked them to do. And let's fast forward like several years down the road when we finally get to passing this ordinance, and they're like showing up, they're organizing, they're doing stuff we don't even know about. Like they really embraced this issue because they understood what it really meant to their community. With addressing tobacco, whether it was smoke-free policy, increasing cessation, increasing a tax, like they're in it. They understand the toll of tobacco on the Black community and the people that they work with and live with and love and all of that. And so now they're one of the leading organizations leading their own efforts. So now they're not just a member of our coalition or somebody else's coalition. Like they're leading the effort now on banning menthol in Atlanta. And we're not even the key group working with them. They're working with CPHE, and I'm not sure if the center's here in the room. And like they've got new partners and new funders and new responsibilities. But if I could put their stuff on the screen, you'd be so impressed with this group. And it's working through organizations like that that help us address these issues and do it in a way that's culturally appropriate. Because we can get funded all day to do this work. And we can go out here and spit stats and tell stories and bring partners to, like, y'all need us, like they need us, but we need them. And we have to be able to do this work together. And so now, and I want to shed a tear because I'm so proud of this group, right? But they're not only doing tobacco control work now, because again, in order to get to health disparities in the community, it's not just about tobacco. And so now they're working on other issues around mental health. They're working on healthy eating and active lifestyles. And they're doing this in a way that is so mature and experienced. And, and it's so good to see. But we try to do that in every community that we work in. And it's not always easy because those things take time. And it's about building relationships and trusting your partners and sharing your resources and doing the things that over time will get you to the end goal. And believing that working with folks in all areas, okay, CPHE is going to love me today because like I'm going to probably talk about them more than I'm talking about my own organization. The Center for Black Health and Equity, I'm sorry, thank you. That's why you got to have good partners in the room. So the Center for Black Health and Equity is just an amazing partner, an amazing organization working on health equity and the Black community. But Kenny Ray is a longtime colleague of mine, and and we've been doing grassroots stuff in Georgia for years. And he would always talk about we needed coalitions that were, and y'all are gonna laugh, the people who know Kenny, multicultural, multi-ethnic, and multi-generational. And he would say it so many times, you're like, oh my gosh, I think I can say this before it comes out of his mouth. But he's right. We need these coalitions, and we need to work with organizations that really bring together multicultural, multi-ethnic, multi-generational. I'm probably missing some multis in there for something, right? But bringing those all together to work on community issues. But let me tell you this other story about when you're not always the right person to do what you're trying to do. Okay, so do I have time to tell another story? I don't even know how much time I have. Do I? Okay, it's probably not even gonna be funny by the time I end up telling the story. Okay, so my very first smoke-free campaign was Jackson, Mississippi, back in like 2005. And it would have been like the first major city in Mississippi to pass a comprehensive smoke-free ordinance. And so we were doing our work, trying to organize and bring in all the partners and all the groups. And so, like every coalition and every campaign, we're like, oh, you got to get the faith-based folks involved, and you need to get the Black church involved. And so we're like, yeah, we got a really prominent Black church in Jackson. I'm like, hey, I'm Black, I'll go talk to him. And so we got the meeting with the pastor, and we're in there and we're having a conversation. And, that saying, y'all know what I'm about to say. what do we use for all health related initiatives when we want to talk to the Black church? Like, why should the Black church be involved in our health initiative? Because your body is a temple. Y'all heard that, right? Right. Okay, so I'm sitting across from this pastor, right? And I'm like, you guys should really be interested in this because of the congregation. I'm using terms, church-like terms, the congregation, and, they're really important. And, your body is a temple. And he's like, and I'm like, that's it, right? I didn't know there was more to it. Like it's a passage that has more, like there's something that comes after that, right? I'm not the most church-going person, so I didn't know that, but it was like the most popular term that we use. I'm saying that to say, so I lost all credibility after that. He ended up being a really good spokesperson for the campaign, and he did our press events, but it was somebody else that had to be that person in between us in the church. I wasn't the right person. But I say that to say we're not always the best person. And again, reaching out and building relationships and utilizing your partners and acknowledging that we're not always the best person, but you need those other people at the table. And being okay with who those people in those organizations are, because we need everybody in this fight. These health disparities are kicking our ass, seriously. And we can't really address the problems. We can't really get to the root of the problems unless we're really bringing everybody to the table. And again, I don't know the data. Plural, right? I don't know the data. I don't know all the details, but I know we got problems in our community that need to be addressed. And I'm gonna work my ass off to figure out who needs to be here at the table with us to help get this done. And so we're excited to be here with you guys today and to support the work that you're doing. And if we can help you in any way that we can, just know that we're always here. And if we're not the best organization or partner to help you guys get that done, I promise you we will help you find who's best to work with you to help you get done what you need to get done. So I don't know if that's what y'all called me here to say today, but God doggone it. And I'm going to be up here 2 more times today. So I'm going to get it right before I get done.
Hello, everybody. My name is Lamar Suber. I am actually one of the board members for Smoke Free SC. And I've had a pleasure of working with a number of you, so it's glad to be here. But question for the panelists. All of you are champions in your own right in terms of your field of expertise, where you are and what you're doing. So my question is, how do you encourage other people to step up to that challenge, to become champions, to continue to work not only with you, but then within the community? I know all of you have touched on it in some way, shape, or form, but what does that encouragement and support look like, so that way those who may feel afraid or those who have stories but may not know how to use them actually step up to the forefront to become champions and continue to help in the work?
You mind if I take a stab at that? Great question. A couple of things that we and I personally try to do is just to really connect with people. I do this work because I have a story to tell. Like, it matters to me. And there's a big difference between having a job and doing it because it's your job, or doing the job because you really give a darn about the work that you're trying to do. I have a story to tell on why I do this work. I'm trying to protect hospitality and service industry workers who are making $3.25 an hour with no health insurance and working in jobs that's making them sick. And somebody's telling them they need to find another job. And I'll be damned if I don't try to do something about that. So I tell that story or something related to why I'm doing this work. And I want folks to trust us with their story, and we want to put them in a situation where they're comfortable. And sometimes it's not always, the first opportunity is not always in front of city council, or not always in front of a decision maker or the media. Sometimes it's just in a small circle where they can talk to people and share that story and know that somebody understands where they're coming from and that they're protected in that space. And they may not be the person that can step up to the next level and be in front, but we've got that story and we've got why it matters to them. And we find ways to engage them in ways that they're comfortable with. And it's not always what we need and want, because sometimes we want more. Like, I'm fighting a battle right now in Shreveport, and we need casino workers to come out. And they are afraid of losing their job. And the alternative is they're going to put secondhand smoke. They're going to put smoking back in the casinos. And that's a big deal. But I respect the fact that they're not comfortable coming out. So what are we going to do about it? You know, and so we need to hustle and do some of that. But part of that is building a bridge and building trust and then finding, again, some of the folks in the middle that if not us, who do they trust? And who are they comfortable with? And building those relationships and trying to move the needle down the line.
Yeah, I mean, I would reiterate exactly what Onjewel has said. Again, I think going back to stories, I think whenever I went through a lot of trainings early on in my tobacco education, health, education days, and I'll always go back to the marketing. I feel like if people really understood the background of what the tobacco industry has done and manipulated the communities, and it angers me, and I want people to feel that anger, of why we've been taken advantage of, only to take lives, money, resources for nothing. So, I try to empower people with some of that knowledge of looking around them. Again, we see what we want to see sometimes, and we miss some of those things that are around us. Again, how it's been inundated into certain cultures. Why are there tobacco stores more on low income areas? Why are they sending mailers to certain communities and not other communities? Who are they supporting? Where are they showing up? And why are they there? Because they want to make someone else a new target. So, I have found that just inspiring people with more education of that kind of background of how we've been taken advantage of, and why I want people to feel less like they are, it is funny. People don't want to speak up about tobacco sometimes because they feel like that's their business. It is, and it was their choice maybe to become a tobacco user, but not always. They were put into these positions or culture that they thought it was okay, and they really just didn't know better. So how do we stand up for those people to really make a difference? And going back to what she said too about people telling stories, we just had that recently too in a community that were fighting for smoke-free air. And there was a lady, her husband worked at a police station for 20 years and that allowed smoking inside. I mean, this was 20 years ago. And he ended up with mouth and throat cancer, never smoked a day in his life. And now she's the caregiver, and to see what he's gone through in his experience. And I really wanted her to come and share that to the city council and kind of why, the dangers of secondhand smoke and why it's important that they become a smoke-free community. But she didn't feel comfortable with that. So we used her for her picture and her message and, finding just how can we use your story or your passion in another area. And again, finding the right fit, and letting people know that they're not alone, that there's a lot of us who've been touched by tobacco, and the dangers of it, and that you're not alone, but your voice can make a difference. And one more, I always tell the story too, speaking of casino workers, New Orleans went smoke-free, which we always said in the South, if New Orleans can do it, anybody can do it. They're like the party city. So, but they didn't have the vote at the time. Well, they had the vote, but it wasn't unanimous. And the open comments, the last person come up was a casino worker who worked there who had lung cancer. The casino had let him go while he was in the hospital fighting cancer. And he came and told his story. There was a unanimous vote after that. That's how much of an impact it can make. And I share that story because it can make a difference in getting something changed in a policy that protects, and then that protected, thousands of people after that in that community. So that was always such a huge impact to show the impact of a story, and somebody speaking out, and to not be afraid. It can make a difference. I'm sorry. I told a lot of stories there. Sorry.
I think that was a great question. I'll start off by my story. As you said. And I think that it's important to recognize that different kinds of stories are important. Sometimes the story is a story you tell with data. Sometimes it's somebody's own personal journey. When I started this work, it was never my intention to be a tobacco champion, and I still don't really consider myself a champion, even though I understand why people might say that. But it was simply looking at the data from what we looked at, and I saw that 3% number in that assessment that we went in, and I thought, that's just how can I wrap my head around this? And then when I brought that up to other leaders at the Department of Mental Health, it was, okay, yeah, that probably isn't right. And I was like, there should be some reaction. There should be some, greater interest, concern, what that's about. And I saw all eyes back on me. Like, okay, so what are you going to do about it? Like, that was where, if I didn't pursue it or take it the next step further, and that's when I brought it to this great committee that we had and started thinking and strategizing, what are the ways that we can work on this? And so bringing your problem to other people who are invested. It doesn't have to be, I'm an MD, and that carries a lot of weight sometimes depending on who you're talking to, but it isn't always the right person, as you said, to bring something to a particular audience. So valuing all of the work and looking at people as potential partners and equal partners, I think makes a big difference, like both of them were alluding to. And I think also, as a psychiatrist and in the medical field, tobacco use disorder is sort of seen as old hat, right? I mean, like, we've known for a long time that people shouldn't be smoking and that it's bad for your health. That's not really controversial anymore, right? So when and there's this, I call it like a turf battle, like, who should own the treatment and identification of tobacco use disorder? Is that the Drug and Alcohol Agency? I don't know very many people who go to the Drug and Alcohol Agency only for tobacco use disorder. And yet, so where does that go? With the primary care physician who's got 3 gajillion other things on their list to do? Tobacco use disorder is a diagnosis in the Diagnostic and Statistical Manual, which is what we use. Our patients are disproportionately affected by tobacco use disorder. We have a duty as physicians to help people with health disorders, including those that are considered psychiatric or substance use. And so I think when I first saw that number and I started strategizing within our own integrated care work group at the Department of Mental Health, and the response, I said, let's train more people to do tobacco treatment specialist training. And I was working with Lamar at the time, and we came up with the idea of having a tobacco treatment champion at each clinic. And we were told, nope, our staff are overworked. There's no way that we're going to be able to do that right now. So you're just like, that's not a strategy you can use. So, okay, what do we take it back to? Okay, I'll take it back to my group of people, which is the medical chiefs, the medical doctors in the field. We're the ones who make that diagnosis. Let's see what we can do with them. And that's when you started engaging with the medical chiefs, that they understood. I mean, they all kind of, I think, felt like, yeah, you're right, we're not doing this. And then you have to take that next step into, which is, well, why aren't you doing it? And the sort of sense of who owns this problem, right? And making it relevant to them so that they understood that, if the medical doctors didn't prioritize it, then nobody was going to prioritize it. So making it relevant to them and letting them know how it affects the patients and the people that they work with. So, and a lot of times people in a community, I think there's a sense of shame if they know there's a problem and they don't want to look at it. Why is that? What's the problem? And giving them skills to address that, just like you were saying with, tobacco use disorder. So why is it that you're not addressing it? And instead of making people feel bad about it, is, well, what can you do? Because there's always some small incremental step that somebody can do that doesn't have to be something that, is radically going to change their world. And once you start building that momentum and making people feel that they're part of your team and that they're part of this process, I think it becomes a snowball effect.
Thank you. We have time for one more question, if anyone has anything. Oh, Dr. Kellie.
Yeah, Dave Kellie from York County. And our Tobacco Free Coalition has tried different ways to engage the business community. And I would be interested in the 3 of you in your different roles, how you've managed to do that, or what kind of messaging you found to be effective.
I'll start out and just say that I don't really work with the business community directly in that regard. So I'm going to pass this along.
And I will say that is very difficult. I think it is, we start with quantity and really just going to as many businesses as possible and to see which ones will kind of take the bait to be a supporter and to speak out. I think a lot of times we find that they will sign on to support, a smoke-free initiative or make a change, but to actually have them speak out is a whole different battle, right? To have them do media. But again, I think if you kind of hit the pavement sometimes, and I mean, this is just from my experience in the cities that I've worked in, is, you keep plugging away, and you'll usually find some that want to speak out because they have their own stories or they have been impacted. Obviously, we start with the easy, low-hanging fruit of those that have already gone or tobacco-free or smoke-free within their business. But surprisingly, we've had some that did allow smoking. Sometimes and they have supported as well. They just didn't want to be the bad guy. So they're waiting for someone else to pass that ordinance or that law within their community. They just didn't want to be the bad guy. So we've had some of those speak out as well. But I will say, I don't know that I've ever found like a formula. Onjewel may know better because she's worked in a lot more communities than I have on it. But it's usually just kind of hitting the pavement and finding which ones stick out. Eventually. And usually we've been able to rally a few, but it's never the majority, unfortunately. I have worked with the chambers before, and I have found that sometimes they put it up to their board to have a vote if they want to support it. I know the one I'm working on in Mississippi right now. And what's funny is the chamber president told me that she actually didn't support it, but her board did, so she's going to do what they tell them. And then she did it in a kind way. She was just like, I just want to be honest with you. I don't believe in this, but my board does, so I'm going to do what they want me to do. And so I have kept them educated, and they've actually spoken to our aldermen some. So I just say you go sit down and have those conversations with them. Again, I know not all chambers want to be involved, but some do. And again, they leave it up to their board that are running it to see if they want to support it or not. So, and we have found some key people through that.
Yes, and I agree with everything Kellie said. And I would add, I think for those really tough businesses and or chambers, some groups have just been able to, they approach it as they're going to listen to them and share with them what's going on, but ask, like, what are your concerns? And kind of just flip it around a little bit so that they don't feel that, whatever the effort is an infringement on them, but that we're giving them an opportunity to share their concerns. We're listening. We're not saying we're going to accommodate you, but we're at least here to listen and hear what your concerns are. And that's at least diffused some of the opposition to whatever it is we've been trying to work on. But it also gives us an opportunity to answer some questions and dispel some myths. And maybe they had, ideas that they were going to lose business or we're telling them what to do, but we can at least address that in an environment, in a situation where it's not too public and it's not too confrontational. And we've been able to get some gems out of that. And if nothing else, we turn opposition to neutral and we can keep it moving. So, yeah.
Thank you. One more quick question, if it's quick.
Yeah, sometimes it's about reframing and finding out what's important to that business and especially larger businesses and corporations when they have their ESG, environmental, social responsibility stuff, right? And they use these terms and they care about the community. We're here to do X, Y. Like, use that to your advantage. Like, they're saying that they're here for their employee health and X, Y, Z. Like, and this is an opportunity to support what you say you're committed to. We're helping you get that done. And that's been useful for us. The casinos don't like it, but we use it against them. They've got all these things that they say that's important to them. And it would be contradictory for you to oppose this effort if this is what you say is important to you. If diversity and health and equity and all of these things, and you're opposing this, it just doesn't jive. So yeah, sometimes you have to find out what's important to them, and it may not match the way we talk about it, but sometimes we have to make it fit. So yes.
Yeah, and I was just going to mention too, because and I do get that question too a good bit, especially ones that allow smoking. But again, right, framing it to it's going to increase their productivity, and they have found communities that do have smoke-free air, smoke-free ordinances have a higher cessation rate. You have less youth initiating tobacco, so it's overall great for the community and for the workforce. So you're selling it back to, hey, this is only going to do your business better because you're going to have healthier people. And you're going to have young people that are coming up that are going to see this as an important component of their life and their neighborhoods and their community, and they're going to stay away, more likely to not use tobacco because of this initiative. So I think that's a great point. And coming from employee wellness, that was huge on what we did with a lot of businesses on tobacco. Unfortunately, that's usually something that a lot of people get still dinged for their insurance, as if they're a tobacco user. So how can we, incorporate now this kind of goes along with what you're trying to do within your own business.
The only thing I would add to that is that, along the lines of what you're saying, is that making points to them on areas that they don't expect. So they'll expect that you'll point out all the health-related issues related to tobacco, but did they think about the environmental issues like cleaning up the cigarette butts that are going to be all over the place, or the other wear and tear on the duct system that they might have to clean out over, that there's other downstream effects to these things that, frequently people don't associate with the main issue that you're coming to, and using that as a viable argument to pursue your endeavor.